shoot, what if I get sued? I got no experience. I got nothing to say. I'm scared to death. So after 5 6 years, somebody trying to come after me is like, "No, I told you. I have a conversation with you. Said that you couldn't raise your arm. There's a nerve damage before the reduction. The dislocation caused the damage, and
Hmm.
there's like, oh, so I mean, it's there are people, unfortunately, they're trying to come after you because you got money and they're trying to, but it's something you can't avoid. It happens.
I think to get to the truth, we need to basically demonstrate, right, that we can reduce, multiple joints an entire year with no major risk, and then we can say, okay, look, here's our numbers, here's our data, and say we can move forward in attempting to reduce if you're in these settings, right? That's what I think that would be the next step.
Yeah. Well, I know like when we have new staff come in and we talk about relocations and if they're comfortable, some people are like, "Oh yeah, I can do it except for this joint, this joint, this joint."
Right.
What are your thoughts around the most difficult joints, I guess, that people consider? Most likely the hip and, the elbow probably. What are those fears, I guess, that you guys see?
Yeah, personally, I think all joints, like I said before, they all want to reduce, right? Because there's capsular negative pressure. They want to reduce. So
Hmm.
then we have to think about in what position is the joint. So an anterior inferior shoulder dislocation is going to be a lot easier than a posterior dislocation. We don't see it though. It's just not a normal dislocation that we see in jiu-jitsu and wrestling. Maybe a posterior elbow dislocation, maybe again, I don't know the data, but maybe football or car accident.
Football, because the way it changed the block, there used to be you had to put your arm up, and then
Mhm.
if you got a huge body gap, and you just dislocate.
Yeah, that
So
sounds.
now it's this. So it's a little different technique. They changed, so it's a little less. But yeah, one of
Yeah,
the thing is alignment, huge body gap, and then just all of a sudden you get pushed down, and then posterior dislocation.
yeah. So
That's
again,
how you.
more still Fuchsia's,
Yeah.
following out ideas. But I would think again, athletic trainers are on the field or on the mat or on the court. So we're there within seconds. So the ability to relocate and just apply traction in a loose packed position of any joint, the joint wants to go back in. It's not trying to reduce after 90 minutes.
Yeah.
So that's hard. Now we've had like just this elbow we had, which was a really hard one to reduce. They went into spasm quick, larger muscles, a little harder to
He was a
reduce.
big guy.
I don't think he was too big of a guy. I can't really recall.
Okay.
Uh,
Probably like medium. He wasn't as big as our big
yeah,
boys.
definitely female joints, less musculature, smaller frames have definitely gone in a lot easier. Just in my anecdotal evidence, but again, straight traction, no crepitus of any joint typically it wants to go back in. Yeah. You just have to hang on. And the way I think about reductions is I will hang on a joint, so you just get this like reciprocal inhibition. I'll hang on a joint for 2 minutes. I've hung on a joint for 5 minutes before, sweating my ass off. Me and Chris just hanging, one guy stabilizing the scap and me just hanging on a shoulder, like all my body weight for minutes at a time. Like it's not going to go. And finally it goes. So, and then some people, you barely touch it and it just reduces, right? It's almost like
Right.
a,
Right.
so.
Go ahead.
Hey there, my name is Gabrielle Villa. I'm a Master's of Athletic Training student at Western Carolina University. I'm gonna reduce 4 joints in 1 take. Here we go. Here we go. Well,
Hello. There you go. The last one. Come on. Ooh.
there we go.
What is
It
it?
was the heels.
Yeah. Well, and that's where it was interesting after we had posted on Instagram of that elbow relocation, how many people were like, well, that's the wrong position, or, so many
Yeah.
critiques. And it's like, well, I mean, in that moment, that's the position that we decided to choose, and flipping him over wasn't going to be necessarily conducive to anything, and moving him around. So I don't know. Everybody thinks they have the right answer, but they're not in that moment.
Totally agree. And that, I started changing. For personally, I started changing it up a little bit with the elbow dislocation, laying them prone and putting the fulcrum underneath the antecubital fossa. That seems to be the best method, in my opinion. But I have, like, we've had a lot of people comment on the position of the shoulder. I go foot in the axilla. People say, "Oh, that's horrible. You're going to cause a brachial plexus injury, some axonotmesis or whatever." And again, like, we've been doing this for 20 years now.
Yeah.
Nothing. Yeah, but it's nothing coming back at me, at least, So
Yeah. Well, what about the ankle dislocations? How can you talk that through a little bit?
yeah, ankle dislocations are the easiest because they're just, from what I learned from another ortho, basically picking up the great toe will reduce a talar dislocation. Just straight traction of the great toe. Now, typically, I'll go out. We've had so many of those. I'll go out and just do like calcaneal and dorsum of the foot and just cause straight traction. And that nothing's really attached to that talus dynamically. There's no tendons attached to it, so nothing's really holding it other than ligamentous structures, but they're not, neurologically engaged at that point. So it seems to go in pretty easy. We've had really good luck with ankle dislocations. They seem to want to go back really quickly.
Yeah.
Yeah.
Toki, have you made a simulator for the ankle yet?
It's coming up. So next. I mean, we are thinking about TMJ next or ankle joint with the pulse function. So if dislocate, pulse missing, so we have to reduce it to get the pulse back on. So
that would be cool.
Yeah. So let me ask you this, Toki. Why mandibular dislocations? You think that's a common one?
Well, so this is the thing. I made it because I was tipsy again, and I made it, and then and then I got some dentist doc friends, and then take it over there, and they say, yeah, that's interesting. And then I went to the military base. I have a base here, and then the doctor looked at it, like, you don't need to make one. It's like, so what do you mean? How are you going to reduce it? You don't need to reduce it. Use the gagging reflex. So what he said was use the Q-tip, just rub back against your throat. The human body just, it's going to reduce it back. Like, wow, really? It was like, whoa. I never try. I don't know. I mean, if you've seen it, please let's try. I mean, let me know. You see a lot. I haven't seen it yet. So,
we'll tell our staff.
Yeah,
it's
seriously.
A shallow joint, right? It's a very shallow fossa.
Yeah. So I don't know. It might work. Sounds like I don't know.
Wow. We get it because people tuck their chin and they get this choke, right? And they try to block it with their chin, so it just pops it right out. So I go in, thumbs in the mandible, which is probably, dangerous because people can clinch down, but I'll glove up, go thumbs on the molar, and just do straight like anterior drawer, distraction and anterior drawer. And I've had luck both times with that.
Do you do face-to-face?
Yeah, face-to-face.
Okay, so the Japanese technique, somehow, they go to the patient on the facing up, they go to the head side and put the hands from the top.
And pull up?
Push down, push down in. I mean, you got to push in a little bit and down.
Oh, wow. Interesting. Yeah.
Yeah.
Both times I went thumbs inside the molars, my fingers like on the back of the angle of the mandible.
Right. Okay.
Pulled forward, and again, I felt it. It literally wants to pull right up.
Right.
Yeah. So, and both times, like, I feel so much better. I'm like, gosh, don't range it, right? Let me just like tape you shut, Yeah.
Well, so with young athletes with their growth plates that aren't fully fused together, what is the youngest that you guys would do a relocation on, I guess? Or does it matter? Because would they still fracture that growth plate in the ER?
Well, like we talked previously, when I put my hands on it, the shoulder one, if I, ask them to rotate out a little bit, they feel, cracking, it's like, out, go to the ER. That's the age 13, the 8th grader football player or freshman football player. That's the age I really do not like, because that really high possibility that's the case. So
yeah, I would go back to the same methodology. If you feel crepitus, it's a no-go.
Yeah.
I did have years ago. I had a kids tournament and a girl dislocated her shoulder. I reduced it and it kept on coming out right in front of my eyes. It
Wow.
would stay in. So either she's in some type of spasm with those tissues, or the joint capsule is already torn, or just stretched out, or neurologically just not engaged. But I would reduce her and literally just slip right out. And that was true the first time dislocated her. I remember her very well.
Wow.
Yeah, that's the only one I've ever seen like that.
Gotcha.
Yeah.
Any
Well,
difference?
there's some people that have a condition.
Oh,
What,
yeah.
what do you call there's some people that have loose joint condition, some kind of disease. I don't know.
Oh, yeah. Yeah, people are really Ehlers-Danlos.
Yes.
Yeah.
So, but
I didn't ask. I didn't know anything about Ehlers-Danlos back then. I guess that's possible. This was years ago, so yeah, she could be hypermobile. Could have been.
Yeah. First time dislocators and chronic dislocators. Do you guys have any feedback on that?
second, third time. I mean, it's surgical. I mean, I hate to say it, but yeah. I mean, some people. Let's say, Old Tiny. He's sublux, which he's the pitcher and he can throw pretty fastball, which means he's got MDI. So I assume he'll be fine. But some people, the same subluxation might be the end of the career. So
Okay, he'll be great. You know why? Well, you know why she'll be great?
why?
Because he's a right-handed pitcher. He's a left-handed batter and a right-handed pitcher.
Right.
We don't.
That's right. That's right. Yeah.
But I would say that Shelby, I just sent you that to post on Black Belt, that Muay Thai fighter who reduced with the ring. He went up to the ring rope and put his ring rope underneath there. Great idea, fulcrum, and then he squeezed down and it just relocated.
Yeah.
Obviously, he's a chronic dislocator. Otherwise, he would.
Right.
Do that.
Yeah, I've seen some guys, they put like some kind of bottle or something and just I had one of the YouTube video. I have you did the technique. I put my arm underneath and then said, that works too.
I used to do it. I did a towel roll. And I towel roll, and then I just push down on the humerus. But what I didn't like about that, it just applies so much torque to the humerus, pushing down on the elbow with that. I just felt like it was so much torque and a bit more painful. And then I started moving to this more axillary pressure I do. Yeah.
Cool.
Yeah. So for younger athletic trainers, obviously, Toki, you have a simulator, but do you have any other ways to practice relocation?
Well, I mean, so that's the thing. I mean, now they have to teach, but all those clinical professors, they graduate from OKD standards, so they don't know, they didn't learn, so they buy it and it's like, well, and then we want to teach, but we don't know how, so it's like, okay, we can do workshop. I do that, So the strange thing is, if you buy my product, they have to learn how to dislocate the joint on purpose.
Interesting.
So my elbow model. So you have to dislocate, right? And then you have to reduce. So it's like, So
show the elbow model again.
Elbow model.
Cool. So he's dislocated right now, right?
It's dislocated. Yeah. So, just sit in position, maybe, and then push and pull in.
Okay.
Yeah.
Okay. And then how do you dislocate him?
And just little turn.
Okay, you rotate him, dislocate.
Yeah.
Okay, cool.
Yep.
Right. Great product. Great idea. And I love it again because you're answering a question, and the question is, when are we going to have an opportunity? We watch all these videos of other people do it, but you never get our hands on anybody to do it, because even if we did, somebody would probably take over. They get scared. I do that too on my own athletic trainers who we hire. I get worried. I'm like, I got to do it. And I jump in. That's mine. Huge fault of mine. But, I love the idea here. Great.
Yeah. So now I do, that's my main thing is now is a workshop. I don't sell my product anymore. Just got too busy, and there's a company took over my sales part of it. So I can focus on workshop. So I do nothing but workshop and go places, go conference. And so.
Great idea. Cool. Great idea.
Yeah.
Yeah.
Ethan, what's the craziest dislocation that you've seen or had to deal with?
Oh, we had years ago at PANS, we had a tibiofemoral dislocation, and that's a rarity. Um, it was a female semifinal fight in Irvine, and her tibia was completely pulled forward, and it was like tinting the skin really, really bad. Her patella was relocated, so it must have been stretching the heck out of the patellar tendon. Obviously, her cruciate ligaments are probably gone.
Yeah.
So I had her on her back, hip at 90, knee at 90, and I straddled her lower leg. I squeezed her lower and I pulled it. So I had my hands on her like hamstrings and I pulled with my body and I pushed posteriorly and it went back in. Does that make sense? Yeah. She ranged her knee. I did her just basically sagittal plane ranging. Then I just did kind of like a little meniscal ranging. And she goes, I want to go. I go, there's no way you're going to. So, but here you go. She went, she played half guard right away and she stopped right away. So I gave her the opportunity because it wasn't a concussion or neck injury, but her.
Right. Oh,
Yeah.
So that was probably the gnarliest one. The ones that look really, really bad, like patellar dislocations to the crowd, the ankle dislocation with one of our big fighters we had years ago looked really, really bad. So I think, visually some of these look really, really bad, but they're not hard to relocate or reduce,
Yeah. So legalities. I mean, I know California is a little different, so I'm sure Ethan, you have Dr. Elmo, I guess, who oversees you. But obviously for legality reasons, having a supervising physician, talk to them about it and talk about the risks. Reviewing pertinent employee related documents when you're looking to relocate, and then written standing orders, and then checking that your malpractice insurance coverage is going to, cover you in these situations.
Mm-hmm.
But any other problems that you guys see with dislocations that people should be aware of?
Scary parents.
True.
Parents are like my biggest fear, and that's why working kids events are really hard for me now. Parents they could just turn on you, and athletes can turn on you too really, really quickly. Athletes either love you or you're the villain, and parents are the same way. They either love you or now you're the villain. So I'm more scared of the parents and them wanting to be litigious than I am about anything else, I think.
Yeah. Anything from you, Toki?
I mean, like I mentioned about protect yourself. That's the thing you can do. And even though, like I said, people can come after you. So,
Yeah.
I hate to say it, but
yeah.
Yeah, I think that's everything in athletic training, right? We're either completely loved or we don't get a lot of recognition for all the great things we do with athletes and the tenure that we do with some of these teams. But when you do one thing wrong or they think you did wrong, then it's let's blast you all over social media, let's blast you to the public, let's blast you to to the professional standards. So it's really, really hard. But I just think that athletic training should have a little bit more leeway to start some of these things that we see so much, to waste resources and call it paramedics, waste resources in the ER, for some basic medical things that we could do. I mean, it makes a lot of sense to me.
yeah. But it's like you also say, it's a process now. All the athletic training program, they have to teach you reduction technique, and they start teaching it, and then hopefully they learn, and so when they see the first one, and then they get to do actual reduction instead of, like you say, instead of going to the emergency room and get reduced right away, and all they have to do is next day get an X-ray, AP lateral, start doing the rehab right away, and they still full 5 weeks out, maybe 2 weeks, you might be able to play in the senior year. That's a great outcome to me. So hopefully